And today we're going to be covering jaundice. Well, the first part of jaundice, and I'll let you know exactly which parts of jaundice we are going to be doing today. For those of you who don't know me, my name is Azim. I'm one of the co-founders of BiteMedicine. We've been running these webinars for a number of months now, and we're so glad to have so many new people join just over the last couple of weeks as well. So welcome to everyone who is new and everyone who has watched lots of our webinars in the past as well. So what are we going to be doing today? Well, today we're going to be covering jaundice, as I said, and the target really audience here is going to be medical students in clinical years, but also preclinical years as well, because as I'm sure you guys probably know, jaundice it's really important to have a good understanding of the physiology underlying jaundice before we start talking about the conditions even, and this is really, really important. So this is going to be quite physiology heavy, but also of course having some clinical bits in there as well and covering the jaundice classification as well. So hopefully we're aiming around 60 minutes or so, and then our future webinars will be going into more detail on pre-hepatic, intrahepatic and post-hepatic jaundice as well. But as I said, physiology is going to be the main focus here today, and then linking that into clinical features as well. As we normally do, pathophysiology going through all the way to prognosis. We have one case in this webinar, but we don't actually focus too much on the case itself because we'll be doing lots of other different bits and pieces. So we also use, of course, menti.com. So if you have your phone to hand or any other tablet or device, we can do our interactive questioning as well. So lots of questions as we go along as well. So as I'm sure you've all come through the app as well, so check out our question bank based on the most recent guidelines, as is our textbook as well, with loads of multi-step SBAs, and all our live webinars are also available as well. Our question bank, as well as the online textbook, is updated really regularly with new content being produced every week and updated every month. So yeah, do check that out if you haven't seen that already. So diving into our case-based discussion, this is more just for an opening to get a good understanding of why jaundice is important and how patients may present. So the case-based discussion is going to be about this 54-year-old chap, which you see on the right over here, smiling in a little bit of a creepy way, but there he is. He's presented to the emergency department with abdominal distension, which is there, vague right upper quadrant pain, and yellowing of the skin and conjunctiva. He is visibly cachectic, has a reduced appetite, and has been feeling increasingly confused, which is maybe why he's making that face there. He frequently injects heroin and has done so for many years. Have a look at his observations, and what do we think about those? Anyone concerned? Anyone not concerned? What do we think about the odds? Tachycardic and tachypnic, agreed. Okay, good. Yeah, he's tachycardic. He's tachypnic probably because of all this abdominal distension means he's splinting his diaphragm a little bit. And other than that, you know, those are probably the two biggest concerning features there. And what is this right at the bottom? Really straightforward question. What's this image over here? Clubbing, exactly. So you've got a chap who is jaundice with yellowing of his conjunctiva and abdominal distension with clubbing. So we'll start off with our first question. We're going to head over to menti.com, and the question is, which of the following is true regarding this presentation? Remember, he frequently injects heroin and he's been increasingly confused as well. If anyone is having any issues with watching this webinar or in the chat, etc., webinar itself, in the meeting info, you can actually go directly onto Zoom as well. So that will resolve any issues, hopefully. So head over to menti.com and pop the code in at the top there, 378526, and we can get involved in this first question. I'll have a look at the Q&A as well. Good. Thank you for everyone for their very kind words. Really, really appreciate it. And we're glad that you like the the textbook as well. Is anyone else having issues with the audio at all? Audio okay for everyone else? Cuts off a bit. Okay. Okay. If there's any further issues, just let me know. Okay, so let's see what you guys think. Okay, so the majority of you are saying intrahepatic jaundice is likely, and I would agree with all of you. So this is one thing that we're going to be talking about, is how we differentiate pre, intra, and post-hepatic jaundice, and also, of course, the physiology underlying it as well. If you guys can't see the chat, just go click the meeting info and you can go directly onto Zoom if you can't see the chat in the app. So why do we think this guy has intrahepatic jaundice? Or, well, first of all, let's put all the pieces of this case together, I guess, probably the best option. We have a chap with decompensated liver disease. Now, why do we say it's decompensated? And why do we think it's likely due to viral hepatitis? Well, we pop over here. What is this? What is this distended abdomen? Exactly. He's got ascites, so that's evidence of decompensation. He's increasingly confused, so encephalopathy. So, you know, he's clearly got features of decompensated liver disease, and he's jaundiced as well. He's got a reduced appetite and cachectic. So, you know, he's malnourished. And as we all know, you know, weight loss generally is associated as a constitutional feature, which may be seen in malignancy as well as infection. And this vague right upper quadrant pain, all on the background of intravenous drug use, all suggests viral hepatitis C, for example, hepatitis C or B, which has resulted in inflammation of the liver, hepatitis, cirrhosis, and clubbing. You know, that actually, you know, it's present in cirrhosis, but it's also present in hepatocellular carcinoma. So this patient may have an underlying malignancy as well as the viral hepatitis. So really what this case is to highlight is that jaundice is obviously a sign, but jaundice has loads of different causes, which you really need to piece together based on the other symptoms, signs, examination findings, and crucially, the patient's history as well. So that's why jaundice is such an important topic. But really, you're not going to have a good understanding of jaundice unless we understand the physiology. So let's move on to that. And I'm going to be talking a bit, but we're going to have loads of questions as we go along as well. So click that. Okay, so jaundice, in the basic form of understanding it, is that jaundice occurs due to high levels of bilirubin in the blood. Jaundice itself is going to be yellowing of the skin, and people say the sclera, but it's actually the conjunctiva, due to this abnormally elevated level of bilirubin in the blood. What is bilirubin? Well, it's this normal breakdown product which occurs and is formed following the catabolism of heme, so the breakdown of heme, essentially. And then we can categorize it into post-hepatic, intrahepatic, sorry, pre-hepatic, intrahepatic, and post-hepatic jaundice. So of course that should say pre-hepatic on the left over there. So we'll go into more detail onto how we classify into pre, intra, and post as we go along. Okay, so starting off with some basic physiology. I personally feel jaundice and the physiology and pathophysiology underlying jaundice is not taught particularly well. So the aim of this first part of the webinar, first kind of 60% of the webinar, is going to be making sure you have a good understanding of this. So what do we have? Well, as we said, bilirubin is formed following heme catabolism and bilirubin metabolism. That's why bilirubin is formed. So process of erythropoiesis. So red blood cells are produced in the bone marrow via this process of erythropoiesis. Really straightforward. So you have stem cells in your bone marrow which form erythroblasts and reticulocytes. So these are precursors to your lovely mature red blood cells. So starting to talk about red blood cells, but to understand why this is all relevant, we need to have a little bit of information about them. So what is the average lifespan of a red blood cell? What do you guys think? So this is nice, relatively basic preclinical knowledge, which hopefully you have, but we can work on it together. Okay, just look at the chat. Thank you. Okay, let's see what you guys think. Good. So I'm very glad that we have that baseline level of knowledge there. Absolutely. 120 days. So brilliant. So that's really, really important to know. So going back to bilirubin formation. So as we said, we've got these stem cells in your bone marrow. We're producing reticulocytes, which then mature and grow into erythrocytes, which are your mature red blood cells with this lifespan of around 120 days. Both reticulocytes and erythrocytes do not have a nucleus, and the role of your red blood cells, your erythrocytes, is of course to carry oxygen around the body, and that oxygen is bound to hemoglobin. Really straightforward, but we have to all make sure that we're on the same page right at the start. Okay, so moving on. We have these red blood cells and they're circulating all around your body, transporting oxygen, which is bound to your hemoglobin. They circulate around for around 120 days before they get old or they get damaged, and then they are broken down. But how are they broken down? Well, then we need to think about the role of macrophages. So when these red blood cells are old or damaged, macrophages, which are a type of phagocyte, located in the spleen and bone marrow, they engulf these red blood cells. And this process is part of what's called the reticuloendothelial system. This is essentially just a population of phagocytes in fixed tissues like your spleen and your bone marrow. And these are really, really important in clearance of particles and various substances, as well as cells such as broken down or old red blood cells. So these macrophages then engulf and degrade these red blood cells. So hopefully everyone is with me so far. This is pretty basic stuff. So, but as long as we're all on the same page, that's really important. So now we need to zoom in a little bit closer as to what's going on within these macrophages. So we have our old or damaged red blood cells, which need to be broken down by our macrophages. When being degraded by these macrophages, the erythrocytes or red blood cells will release their hemoglobin molecule. And this hemoglobin is then broken down into heme and globin, as the name suggests. What happens next? So taking a bit more of a broader approach here. So we've got the heme and we've got the globin in the macrophage. Globin is essentially a protein. Globin is then broken down into amino acids, enters your bloodstream, and the globin is then reused in erythropoiesis. So if we focus on the globin, which as we said is formed by the breakdown of hemoglobin, that is reused in erythropoiesis. But then we need to think what's going to happen with the heme, and this is where things get really, really important in the context of jaundice. So let's think more about heme and let's get you guys to answer a question. So this is all going to be obviously covered in the next couple of slides, but let's just assess a little baseline knowledge here. So which of the following is true? So we have our globin, we have our heme, we need to figure out what is going to happen next and how is bilirubin even being formed. And I'll have a look at the chat. We'll talk about CV stuff some other time, hopefully. Evening lectures, I mean, all our lectures are essentially at 5 p.m. generally, so this is no exception. And I'll talk about splinting of the diaphragm in a bit. But yeah, have a look at this question. I know these are quite long options, but it's a bit of a tricky question. Okay. And of course, as I'm sure you all know, I know I'm talking through quite complex physiology as we go along. You can always rewatch this on our website, so it will be uploaded very shortly after the webinar. Okay, so the majority of you say heme is converted to unconjugated bilirubin via heme oxygenase. Not quite. Biliverdin is converted to unconjugated bilirubin via biliverdin reductase. So Good. I'm glad about this because, as I said before, I think this is not taught particularly well at medical school, and this is really, really important to understand. So let's talk a little bit more about this whole process and why this option is correct. I know the other options have lots of other words, unconjugated, conjugated, biliverdin, enzymes, you know. If you don't understand them yet and you haven't heard of them before, you're in the right place. So let's get a better understanding of all of these words here. Okay, so as we said before, heme is released, and this heme is then broken down to globin. So hemoglobin is broken down into globin, which is then reused in erythropoiesis. But what then happens to the heme? So let's focus on the heme now. So heme is broken down into two parts via the action of heme oxygenase. So firstly, we've got iron over here, and this iron, via the action of heme oxygenase, is formed, and this then re-enters your circulation, and the iron is reused in erythropoiesis. Hopefully that makes sense, nice and easy. The second thing that heme is broken down into via the action of heme oxygenase is unconjugated bilirubin, which is all the way down here in the blood vessel, as you can see. Well, how is this formed? Well, first of all, you've got heme oxygenase, which is forming biliverdin, and this biliverdin is then converted into unconjugated bilirubin via the action of biliverdin reductase. On the previous question, if you hadn't heard of these enzymes, weren't quite sure what they're doing, now you know what they're doing, and now you know what they're forming. But why is all of this so important? Well, unlike the iron, which is reused in erythropoiesis, unconjugated bilirubin is not recycled because it needs to be removed from the body because it is toxic. And that's why this is so important, because unconjugated bilirubin is toxic. We need to have an excretion pathway. So let's focus a little bit more on that now. We've got unconjugated bilirubin. Another really a couple of key important points about unconjugated bilirubin is that it has this yellowish orangey color and it is lipid soluble. So therefore, when it's circulating around in the blood, it needs to be bound to a protein in order for it to be carried around. And that protein is, of course, albumin. So remember, we'll talk about this further later on. Unconjugated bilirubin is lipid soluble. And what happens is that it's now bound to this albumin, it's happy to float around in your bloodstream, and the albumin will carry your unconjugated bilirubin to the liver for further metabolism. So now we're going to move on to the liver. But before we do that, make sure everyone's still awake. So as we know, with the albumin, this unconjugated bilirubin is going to be transported to the liver. It needs to be bound to albumin because it is lipid soluble. But once it gets to the liver, which of the following enzymes is responsible for conjugation of this unconjugated bilirubin? And we'll talk a little bit more about this process of conjugation shortly as well. Ignore the option on the far right, not sure why that's happened, but yeah, just focus on these five over there. Just thinking about the case, people are asking questions. Yes, the patient in the case did have clubbing. That is correct. Good. I'm glad. This is relatively straightforward. Gets asked in exams all the time, this question. So spot on, yeah. And if you haven't heard of this enzyme or not sure what conjugation is, that's what we're going to be talking about very, very shortly. So yeah, that's absolutely right. So UDP, glucuronyl transferase, conjugates unconjugated bilirubin with glucuronic acid to form conjugated bilirubin. Nice. So here we go. We were already talking about before unconjugated bilirubin being lipid soluble, bound to albumin, and then being transported to the liver. We're going to talk about this process going on in the liver now because this is also very, very important. So before we talk about these enzymes and what's going on in the liver, an interesting point I just wanted to mention is that the liver actually has its own macrophages. So we were talking about the macrophages before, but the liver also has their own macrophages. These are called Kupffer cells. And these are also involved in breaking down damaged or old red blood cells as well. And just like we were talking about before, they break them down into globin, heme, and that whole process we just discussed takes place. But, you know, just an additional point that the liver has its own macrophages, which are called Kupffer cells as well, and involved in that whole process that we just discussed with the other macrophages. So now we're going to talk a little bit about what's happening to this unconjugated bilirubin in the liver. So in the liver, this process of conjugation is about to take place. So unconjugated bilirubin, as we said before, is lipid soluble. So in order for bilirubin to be excreted, it needs to be water soluble. So for example, it needs to be excreted in your feces and it needs to be excreted in your urine. So this process of conjugation is so important for this process of excretion, because this unconjugated bilirubin needs to become water soluble. So all conjugation involves is turning unconjugated bilirubin into conjugated bilirubin with the addition of glucuronic acid via the action of glucuronyl transferase, or UDP glucuronyl transferase. So that, in terms of on a smaller scale, this process is really, really important. So it's converting your lipid-soluble unconjugated bilirubin to your water-soluble conjugated bilirubin, which then means it could be excreted by the liver in bile. So let's talk a little bit more about bile now and your biliary tree. So thankfully, we've managed to successfully conjugate our bilirubin. So we now have conjugated water-soluble bilirubin, which can then be excreted in your bile because it's now water-soluble. I know I keep saying that, but that's a really, really important point. So the bile, I'm sure we've all heard of bile. It's involved in digestion. It's involved particularly in the digestion of fats and lipids. It contains conjugated bilirubin along with bile salts, so and various other things as well, cholesterol, phospholipids, etc. So you've got this conjugated bilirubin. It's excreted into the duodenum, which is your first part of the small intestine. You've got, it's not shown here, but you've got your right and left hepatic ducts, your common hepatic duct joining your cystic duct, common bile duct, all the way towards your duodenum. Bile, of course, is stored in the gallbladder. Remember, bile is stored in the gallbladder. It's not produced in the gallbladder. And that is why conjugation is so important, because if this process of conjugation hadn't taken place, this bilirubin would not be water soluble and you would not be able to move the bilirubin towards the small intestine for excretion to take place. Hopefully that makes sense to everyone. As I said, you can watch it back in your own time if there's any bits that you missed at all. Back over to you guys. So we've now moved our bilirubin, which is now contained in your bile, towards your small intestine, towards your duodenum. And of course, it's now going to move towards your large intestine. Which of the following is responsible for the brown color of feces? Some questions about Kupffer cells. So yeah, if you just look back on the previous slide, they're called Kupffer cells. They're actually shown on the diagram of the liver over there. So the enzyme is called UDP glucuronyl transferase. So UDP is just the prefix of the enzyme. And we've talked about splinting of the diaphragm, so that's great. Thank you. Thank you for saying I explain things well. It's something I try and do the best I can. Good. Fantastic. Spot on. Stercobilin, precisely. So that is what is responsible for the brown color of your feces. And this is so important when we come to talking about the clinical side of things soon. You know, some of these are indirectly responsible for the brown color of feces because, of course, we've gone through this whole process of unconjugated bilirubin to conjugated bilirubin to stercobilin, etc. So, but the most accurate answer is going to be stercobilin. That's what's responsible for the brown color of your feces. So Let's zoom in a little bit more into the large bowel. So we now know, we've said it already, conjugated bilirubin entered your small intestine and it travels towards your large intestine. So near the end of your small intestine, which is called the ileum, or the start of your large intestine, conjugated bilirubin is then converted into something called urobilinogen. Let's talk about that, urobilinogen. So we've got conjugated bilirubin here, and we're converting it into urobilinogen. This really straightforward process occurs via a reduction reaction by removing your glucuronic acid via the action of these very helpful, lovely gut bacteria. So these gut bacteria act to reduce conjugated bilirubin, therefore removing glucuronic acid to form urobilinogen. Nice and easy, I hope. Let's zoom out a little bit now. So we've got urobilinogen being formed. Hopefully you can all see this okay. Now we need to think, what happens to this urobilinogen? Is some reabsorbed? Is some excreted? Well, the answer is yes to both of those. The vast majority is excreted, but let's talk about the smaller percentage, which is reabsorbed first. So we've got around 10 to 15% of your urobilinogen, which has just been formed, is now reabsorbed by the blood, bound to albumin. However, the vast majority, so around 90%, is then oxidized by other gut bacteria into stercobilin, which is what, as we said before, responsible for the brown color of your feces, once it's excreted, of course. So the key point here is that the vast majority is excreted as stercobilin, which is responsible for the brown color of your feces, whereas the smaller proportion, so around 10 to 15%, is reabsorbed, bound to albumin. Now, here's an important clinical point I wanted to mention. If you have an obstruction of your outflow of conjugated bilirubin, so remember how I showed you the picture of the biliary tree coming off the liver. If you have an obstruction in that process, so you then have a buildup of conjugated bilirubin, there will be reduced stercobilin, and therefore you get pale stool. Really easy, because this whole process is not going to be taking place effectively because there's an obstruction. So reduced stercobilin, pale stools, is associated with obstructive jaundice or post-hepatic jaundice. If you didn't catch that, that's fine. We're going to go into more detail on that very, very shortly. So now let's focus on a little bit more on that 10 to 15% of urobilinogen, which is reabsorbed into the blood. As we said, this 10 to 15% is bound to albumin and travels via the portal system back to your liver. So here we are. So let's say 10% is absorbed, just to keep our numbers nice and even. So of that 10% that is reabsorbed, around 5% of the urobilinogen is then involved in something called the enterohepatic urobilinogen cycle. Essentially, this means it's taken up by the liver and then resecreted into bile again. So 5%, really small amount. The other 5% of the overall 10% which is reabsorbed is excreted in your urine and is converted into urobilin, and urobilin is responsible for the normal yellowish tinge to your urine. Nice and easy. And actually, in terms of physiology, that's really it. Just remember that the urobilin is responsible for this nice yellowish color of our urine. A clinical point here, which some people aren't particularly aware of, and is really important just to mention, is that you can actually measure the amount of urobilinogen in your urine. And if you have a low level of urobilinogen in your urine, this may suggest a kind of a complete obstructive jaundice. Because if you have an obstruction, for example, a big stone in your common bile duct, all of this process can't take place, and therefore you're going to have lower levels of urobilinogen and urobilin in your urine. So that's just a clinical point, is that you can measure the amount of urobilinogen in your urine. I haven't actually seen it done clinically personally, mainly because there's so many other imaging modalities available. It's more just a point to be aware of. And that is the physiology in a nutshell, to be honest. But hopefully now you have an understanding of this physiology, everything we're going to be talking about very shortly will make complete sense when we talk about the clinical stuff. So these are just the diagrams that we were looking at previously. You don't need to relearn any of this. We've talked about all of this. But let's talk first of all about pre-hepatic jaundice. As the name suggests, pre-hepatic just means jaundice, which is due to pathology which occurs before the liver. So all of this stuff about erythropoiesis, about macrophages, about heme breaking down into unconjugated bilirubin and iron, for example, this is all under that pre-hepatic guise because it occurs before the liver. So pre-hepatic jaundice, why does it occur? Well, the underlying pathophysiology is essentially excessive red cell breakdown, so hemolysis. So hemolysis overwhelms the liver's ability to conjugate bilirubin, essentially, and this causes an unconjugated hyperbilirubinemia, which makes total sense because, of course, you've got unconjugated bilirubin here, which is formed by the breakdown of heme. So if you've got loads of red blood cells being broken down, you've got loads of unconjugated bilirubin roaming around your bloodstream. And that's why it's an unconjugated hyperbilirubinemia. So that's really, really important to be aware of, is that these pre-hepatic causes of jaundice are unconjugated. Here are a few examples. So, for example, congenital red blood cell dysfunction, so sickle cell disease, hereditary spherocytosis, for example, autoimmune hemolytic anemias, prosthetic heart valves due to the actual mechanical damage of red blood cells, and a couple of others as well. So remember, this is unconjugated. Just a side point here is that any bilirubin, because you've got to understand, we've got loads of unconjugated bilirubin, but some of it is still going to be able to be conjugated. So any bilirubin that manages to become conjugated will be excreted normally, but it is the unconjugated bilirubin in the bloodstream that causes the jaundice. And also remember, unconjugated bilirubin, as I've said so many times before, is lipid soluble, not water soluble. So there's no change to the color of your urine because it's not affecting the color of your urine, essentially. So those are the really basic causes and principles underlying pre-hepatic jaundice. And next time we'll go into more detail about all of these causes and some others as well. Moving on to intrahepatic jaundice, before I give you guys a few more questions, just to make sure everyone's still awake. So intrahepatic causes are due to parenchymal liver disease, either due to an inability for the liver itself to conjugate, as we talked about already, or an inability for the liver to excrete bilirubin. And here are some causes. So you've got alcoholic liver disease, viral hepatitis, which we think our chap in the previous case had, but he may have had an underlying hepatocellular carcinoma as well. So that's also a cause. And there are a few others there as well. So PBC is primary biliary cholangitis, PSC is primary sclerosing cholangitis, both involved in damage to bile ducts and thought to be autoimmune. So, as we said, intrahepatic is due to parenchymal liver disease. Viral hepatitis often and predominantly causes an unconjugated hyperbilirubinemia, as do hepatotoxic drugs such as rifampicin. The reason I'm mentioning that is because it's just important to note that intrahepatic jaundice, due to any of these causes, can be conjugated and can be unconjugated, or give you kind of a mixed picture, if you will. And the reason that is that although a lot of intrahepatic jaundice is conjugated, there are unconjugated causes as well. So if we look at the final row over here, where is it? Crigler-Najjar and Gilbert syndrome. So these can be categorized as pre-hepatic or intrahepatic. So Gilbert's, for example, is really, really important because it's so common. It's essentially just a mutation in a specific gene which causes reduced activity of glucuronidyltransferase, and it causes a very mild unconjugated jaundice. And similarly, Crigler-Najjar causes an unconjugated hyperbilirubinemia, and this is due to pathology within the liver because of absence or decreased activity of your glucuronidyltransferase. But it can also be classified as pre-hepatic as well. So really just a point to mention is that it can cause conjugated jaundice, conjugated hyperbilirubinemia, or unconjugated. Particularly if the liver becomes cirrhotic, for example, which a lot of these conditions can cause a cirrhotic liver, this can then cause a degree of obstruction within the biliary tree, and that would cause a conjugated jaundice. So that's just to be aware of, is that it's not completely black and white with intrahepatic jaundice. So hopefully that makes sense to everyone. And really just harking back onto our case-based discussion, as we said, we think this is intrahepatic because this chap likely has a viral hepatitis, hepatitis C, for example, because of his intravenous drug use, which has then caused, obviously the intravenous drug use has caused the viral hepatitis, which has caused potentially cirrhosis and decompensated liver disease. And the clubbing may indicate, although it's present in coronary liver disease, it may indicate hepatocellular carcinoma as well. So that is how we're linking all of our physiology with our clinical features as well. So moving on to a question now. So which of the following causes of jaundice is most likely to cause pale stools and dark urine? So if you haven't heard about that relationship, pale stools and dark urine, then that's something that we're going to be covering shortly as well. Lots of questions. I'll cover some of those questions right at the end. Good. So it sounds like the majority of you have some understanding of the concept of post-hepatic or obstructive jaundice, pancreatic cancer. So pancreatic cancer is a cause of obstructive or post-hepatic jaundice, because of course you've still got the production of conjugated bilirubin, but you have an obstruction of bile flow, and that causes dark urine and pale stool. But if you don't quite understand the physiology, you're thinking, I don't quite understand why that's happening. Well, let's talk a bit about that. Then, so post-hepatic jaundice, so pancreatic cancer is one of those causes, for example. Post-hepatic jaundice is also called obstructive jaundice. It's also called surgical jaundice as well. And the reason it's sometimes called surgical jaundice is because a lot of these causes require surgical intervention. Essentially what happens in post-hepatic jaundice is there is an impediment of bile flow due to partial or complete obstruction of this extrahepatic flow from the liver to the duodenum. That obstruction can occur within the bile ducts themselves, that can occur more distally within the pancreas. So this diagram really just to really make sure you have a good understanding of the anatomy and the relationship, the close relationship between the bile ducts and your pancreas. If you have pancreatic cancer, that can cause compression of your bile ducts and therefore an obstructive jaundice. And of course, this is going to be a predominantly conjugated hyperbilirubinemia because you've got conjugated bilirubin passing down over here. So anything that's going to impede that flow is going to cause raised levels of conjugated bilirubin. Other causes include, for example, a common bile duct stone, as well as pancreatic cancer, cholangiocarcinomas. Certain drugs can cause cholestasis as well. So some drugs that spring to mind, things like the combined oral contraceptive pill, ampicillin, erythromycin, these can all cause conjugated hyperbilirubinemia. And then there are a couple of autoimmune causes as well, like we mentioned before, PBC and PSC, which can damage your intrahepatic in the case of PBC, or extra and intrahepatic in the case of PSC. And that's why you get kind of a large amount of conjugated bilirubin in your blood, because this whole process is being impeded by some kind of obstruction, whether it's mechanical obstruction, whether it's strictures, whether it's drug-induced, whatever it may be. But that doesn't quite answer that question of why are we getting pale stools and dark urine. So pale stools and dark urine is a feature of obstructive jaundice. And this is so, so important when you guys get to your foundation years, particularly if you're doing a general surgical job. If a patient presents with jaundice, it's a barn door question, something that has to be written down on the history. You have to ask, have you had pale stools and dark urine? Obviously, you're going to investigate regardless, but in the history, it gives you some vague idea of the underlying cause, because in your mind, if a patient has jaundice, you need to be trying to categorize them into pre-hepatic, intrahepatic, or post-hepatic. And if they have pale stools and dark urine, you're leaning more towards your post-hepatic causes. For example, common bile duct stone, pancreatic cancer, cholangiocarcinoma, along with those other causes as well. But why do you get pale stools and dark urine? That's the big question. So let's have a think. So you've got some kind of obstruction, all those causes we just discussed, for example. Something is impeding this process of bile or conjugated bilirubin within that bile moving from your liver to your duodenum. So essentially, conjugated bilirubin can no longer access the intestinal tract. So because your conjugated bilirubin can no longer access your GI tract, remember, that then means it can't reach the ileum, it can't reach your large bowel, and there's no further conversion to urobilinogen, there's no stercobilin being produced, and therefore you get pale stools. Because remember, stercobilin is responsible for that brown color in your stool. So that's why you get pale stools, nice and easy. Why do you get dark urine? Well, you have this excess of conjugated bilirubin building up because of this obstruction. This is infiltrated into the urine without urobilinogen because of the obstruction itself. And then it's that excess conjugated bilirubin which gives the urine that abnormally dark brown color. And that is why post-hepatic or obstructive jaundice causes pale stools and dark urine. So hopefully that makes sense to everyone. There are some, obviously the stool hopefully doesn't look this pale, because that's totally gray. But have a look at some pictures. I couldn't get any copyright-free images of it, unfortunately, but I'm sure there are some on the internet. So good. Hopefully, and just also a side point, I see a couple of questions about a mixed picture of jaundice. So in some cases, for example, intrahepatic jaundice, you can get mixed because, as we said, it can be conjugated, it can be unconjugated. You may get some change to the stool, some change to the urine, but often not. Often the significant changes to stool and urine will only be present in post-hepatic jaundice. And really that's what this table is summarizing for you guys. I think I thought it'd be nice to try and compare all of these features in one place. So we've covered the physiology. We know the different causes and underlying physiology which underlies pre-hepatic, intrahepatic, and post-hepatic. Hopefully we now understand why in pre-hepatic jaundice, for example, due to any hemolytic condition, you get unconjugated hyperbilirubinemia, but because unconjugated bilirubin is lipid soluble and not water soluble, it's not going to affect your urine or stool because it's not involved in that excretion anyway. Whereas post-hepatic will certainly, in significant obstruction, for example, the common bile duct stone, it really can affect your urine and stool because of that physiology we just discussed. And then intrahepatic, which has these variety of causes, often conjugated, can be conjugated and give a mixed picture. And often the urine and stool will be unaffected. But as I said, if you get that mixed picture, there may be some change there. I wouldn't recommend, thinking this is all totally black and white. There's going to be some overlap here. Just because a patient has no change to their stool or urine does not mean they don't have post-hepatic jaundice, for example. You still need blood tests, you still need investigations. And next time we'll talk about what those blood tests and further investigations, imaging, etc. actually are. But this really is a nice, simple overview of the physiology that underlies jaundice, some key causes of pre, intra, and post. And we're going to go into more detail next time into all of those causes as well. So hopefully this was really, really useful for you guys. You can watch it back in your own time. But of course, we have a top decile question as well. Just to finish things off, it wouldn't be a BiteMedicine webinar without a top decile question. So all invited, no prizes today, unfortunately. We will hopefully have another big quiz at some point. Remember, this is a tough question, but I actually think it's totally fair. It actually came up in my finals. But let's see how you guys get on. So the faster you answer, the more points you get, and then we'll see the leaderboard at the end. So have a read of that. I'll have a look at the... Okay, 25 seconds left. Okay, coming up to 10 seconds. Three, two, one. Okay, good, good. As I said, it's a tricky one, but one which is actually very, very reasonable in your exams and has come up for me in the past. So if you haven't heard of Marizzi syndrome or Marizzi, I don't know how the Italians pronounce it properly. Let's talk a little bit about that because that's what the key thing to be aware of is here. So Marizzi syndrome, the definition of it is common hepatic duct obstruction caused by extrinsic compression from an impacted stone in the cystic duct or the neck of the gallbladder. So this strange, weird stone, the best thing I could find, unfortunately, is a stone with a gallstone within the cystic duct. It can then cause compression of your common hepatic duct. And this extrinsic compression is known as Marizzi syndrome. If you don't have a good understanding of the anatomy, remember your left and right hepatic ducts come off here. They form your common hepatic duct, your cystic duct, which then forms your common bile duct. And that's all Marizzi syndrome is. But as I said, often does come up in exams, even though it's super, super rare. They do like to ask it in exams for some reason. So let's take a look at the leaderboard and see how you guys did, or who the winner was. Let's see who the winner was. And yeah, we'd love for you to fill out the feedback form at the end. I'd be very grateful. Oh, Jazz, you superstar. Jazz, take a bow. Congratulations to everyone else on this list as well, particularly Ascites. That's a great name. Well done. Congratulations. We'll hold another big quiz with prizes and stuff soon because I think they're good fun. But thank you so much for sticking around all the way till the end. Let me see if I can get to the next slide because we would love your feedback. We've covered this, relatively straightforward, less than an hour. Nice, easy slides. Hopefully you guys have understood this pretty well. And then we're going to go into more detail next week and maybe the week after as well into the nitty-gritty of pre, intra, and post-hepatic jaundice. As I said before, check out our textbook, check out our multi-step SBAs, all based on the most recent guidelines. And we would love your feedback, please, because we have to keep improving and we keep updating all of our content. So I'll pop the feedback link in the chat. Please do leave us your feedback, and I'll try and answer some of your questions. Are the gut bacteria commensal? I'm assuming you mean in the process of conjugated to urobilinogen, etc. Yes, yes they are. This was so good. When will the next jaundice session? Oh, thank you everyone, yeah, for your kind words and things. So grateful. Without you guys, this whole platform would not exist. So thank you. Thank you, everyone. When will the next session be? Will these be on the weekend too, please? Yeah, I can try and do it on the weekend if you guys prefer. But yeah, maybe I'll try and do it on the Sunday if that's something which you guys would like. Thank you very much. That's very kind. I'll talk in more detail about drugs that cause cholestasis, etc. Next time. So yeah, just because people are leaving, I don't want everyone to miss out on that. Yep, I can put the feedback link there. Thank you. Which causes are likely to present as a mixed picture? I guess the point is that particularly in intrahepatic jaundice, because the process of conjugation is taking place in the liver, we need to understand that intrahepatic causes of jaundice can be generally unconjugated or unconjugated in terms of your bilirubin, depending on which process within the liver is actually being affected the most. If it's predominantly the process of conjugation which is being affected, then obviously it's probably going to be more likely to be an unconjugated hyperbilirubinemia. I don't think you really need to know exactly which causes are unconjugated, which are conjugated. Just be aware that intrahepatic often can be both. Things like Gilbert's and Crigler-Najjar, which can be classified as pre or intrahepatic, those are, you know, unconjugated causes because the process of conjugation is being affected. So hopefully that answers your question somewhat. Is it worth learning Dubin-Johnson's? And yeah, I mean, basically the question here is there are lots of other causes of intrahepatic and pre-hepatic jaundice. I wouldn't get bogged down in all the nitty-gritty details. I would probably learn the key causes that I put on the slides, and you know, on the next few lectures, if I mention more causes, probably those as well. But I wouldn't get too bogged down in the more niche causes, essentially. Does this come up on the urine dip? I think when measuring so yes, you can measure urobilinogen in the urine. It's not a routine test on the normal urine dip, but you can measure it as a specific test. But as I said, often not done in clinical practice now, mainly because there's so many other investigations you can do for suspected obstructive jaundice. Most of the other questions here are to do with management tips for final years, physiology revision sessions, electives and things. I'll try and answer these some other time, to be honest, mainly because there's so many of them. But I think we'll do a lecture on basic tips and advice for medical school. If you think that would be useful, that's something we'll definitely try and do in the future, is how we would recommend going about specific things at med school. Good. And yes, of course, our SJT sessions are coming up soon. I've lost track of the time, but pretty soon. So if you have any questions or concerns, or you know, you're really stressed about how to smash your SJT next year or this year, yeah, check that out as well. But I think I will leave it there, guys. There are still quite a few questions here, but I think we'll cover those in the webinar on how to smash med school, basically. But yeah, take care, everyone. Have a wonderful Sunday afternoon, evening, whatever time it is, wherever you are in the world. And we'll see you next week for lots more webinars. And in the meantime, yeah, take a look at our textbook and questions. And please tell your friends about us, because that's how we survive. Thank you, take care, and enjoy the weather. Goodbye.